Hello and welcome to the first ever National Black Harm Reduction Network national webinar. I'm Tracie Gardner and I'm the executive director, and I am so excited for today's discussion. You all are part of our history now. And so again, it's our first. So we will strive for excellence, but if we don't get there, we'll do it next time. An important reminder, caveat, and I'll repeat it maybe at times throughout the webinar. Everybody is welcome to this webinar. Everybody is welcome to National Black Harm Reduction Network's public events, but we center Blackness. We are focused on by us, for us, to address the harms that are unique to Black communities in this country. Today's focus is on the drug supply. And so we are holding the Know Your Supply of Black Harm Reduction Dialogue. I want to give you a little bit of time to read some Bible from Elaine Brown. Today, we're going to explore the role of drug checking and harm reduction and what's possible when these programs are led by our communities and how to access funding and support and sustain this work. This dialogue is part of a larger movement, and it's one rooted in the urgent need for Black communities to care for ourselves as traditional systems of care have failed us and continue to fail us and seem like they're gonna fail us in the near future. Black people deserve access to life-saving tools, emerging technologies, and culturally grounded public health solutions that see us, respect us, and keep us alive. And so I am going to, hold on, y'all. What you got? Next page. All right. Instead of doing traditional Q&A, we're collecting your questions throughout this session, and this is going to help us understand what's most important to you, and it's going to shape the future programming and the resources that we want to be able to supply to you. If you've got a real burning, itching question about this or for anything related to National Black Harm Reduction Network, which we have been lovingly called NBHRN, right? You can send us information or questions at info@nbhrn.org. And so want you to stick around till the end, and I'll talk a little bit more about what's on deck and what we'll be doing next. I am now delighted to introduce Shimeko. And I just do Shimeko as one word, like Beyonce, like Dion. And Shimeko comes to us, if I could figure out how to move this thing. Shimeko is a founding member of the East Bay Drug Checking Collaborative in Oakland, California. Oakland. Shimeko has been involved in street outreach with Berkeley Need and Punks with Lunch, West Oakland. And Shimeko serves on the POC Council for the California Syringe Exchange Programs Coalition. And Shimeko is research assistant at Columbia University's Social Intervention Group, which is the focus on intimate partner violence and community engaged harm reduction strategies. So without further ado, and let me just say, Shimeko is just one of the new, I'm going to call it new Gs, right? We got OGs and we got new Gs. People who are coming into this work, who are doing this work, and really just about what the folks who helped found NBHRN envisioned. So without further ado, Shimeko is going to take us as teacher into our class. Students behave.
Hello, everyone, and thank you, Tracie, for the introduction. I'm going to quickly walk through today's agenda. I'll start with some background on why we need stronger harm reduction practices and drug checking technology that centers Black communities. I'll highlight some national trends, and then I'll hand it over to Leonardo Dominguez Gomez for the lowdown on operations and insights into his role as lead drug checking technician at the NYC Department of Health and Mental Hygiene. Then Mark Jenkins, the NBHRN board chair, will give us some insight on what it looks like to bring this technology to your community. And lastly, Tracie will close us off with a few notes on what's coming down to the pike. Next slide, please. But first, I want to talk about what's happening right now. We're facing legislation designed to either enslave us or erase us altogether. The current administration seems determined to drag us back centuries, all while dismantling the already fragile systems of care many of our people rely on. Medicaid cuts, which fund about 60% of substance use treatment and medication access in this country, will have devastating consequences. The executive order ending crime and disorder on America's streets is state violence. It doesn't just escalate the war on drugs, it deepens systemic traumas and displaces people who are already doing whatever they can to survive. This phrase, evidence-based, appears in the order, but it's clear that it's being used loosely. Forced treatment and punishment without real care or support are not just ineffective, but they're dangerous. But we need to be honest, right? There's no single solution that'll save every life. There are many pieces to this puzzle. But one thing is certain, the first step towards saving lives is helping people feel like their lives matter. Sometimes that means taking matters into our own hands and building systems of care when larger systems fail us. That's part of our legacy. You see, in the 1970s, the Young Lords, alongside the Black Panther Party, the Republic of New Africa, and White Lightning took over Lincoln Hospital in the Bronx. At the time, Lincoln was known as the butcher shop for its genocidal conditions. There were no public services for people trying to detox from heroin, which was a big issue at the time. So the community stepped in. They launched an acupuncture-based detox program. They called in a Chinese medicine doctor and collaborated with him to learn skills that at the time were inaccessible in the English language. They built something revolutionary. Even after the program fractured, many of the young people who had harnessed its its value and learned its skills went on to form the Black Acupuncture Advisory Association of North America in 1979. This story matters not just because it was care, but because it was something by us, for us. They took an emerging technology, mastered it outside of traditional systems, and built something ahead of its time. Now that's what I believe we're doing now. We're learning to use FTIR to protect and empower our people. We don't need permission to lead in care. We've done it before, and we're going to do it again. Next slide, please. Next, I want to share with you a chart. This shows the national overdose trends. For the first time in over a decade, overdose deaths in the US have declined by about 27% between 2023 and 2024. And now it's hard to pinpoint a single reason, but many folks attribute the drop to expanded access to over-the-counter naloxone, known as Narcan, increased use of fentanyl test strips, the end of pandemic isolation, and the slow but growing reach of drug checking programs. There's one more sobering take. Some believe that part of the drop is due to the possible reality that many people have already died, leaving fewer people who use drugs. Next slide, please. Now this chart breaks things down by race. When we look at the data, Black people in the US, specifically Black men, have experienced a 4-fold increase in overdose deaths since 2015, the year the national spike really took off. One study projects that we'll still see a sharp rise in overdose deaths amongst Black men in their 30s and 40s. Before I go further, I want to highlight the top line on this chart. That line represents overdose deaths among American Indian and Alaska Native people. It's critical that we build coalitions and share resources. We're up against systems that don't care whether any of us survive. Division only makes extinction easier. We need to support Indigenous communities as they care for their people. But I also want to name that this deserves a deeper conversation than we have time for today. So, the overdose crisis, it seems to lose urgency when Black people are the ones dying. I recently attended my first international harm reduction conference in Colombia. I was hoping to learn more about infrastructure, how harm reduction is done differently in places where issues aren't so racialized. How are the most marginalized people cared for? There was incredible work being presented, especially in Colombia and Spain. But what struck me the most is what happened off stage. On the last night, I went to dinner with a small group of Black harm reductionists from around the globe, from the UK, from South America, or South Africa, Colombia, Kenya. Sitting together felt like a house of mirrors. We were reflecting the same reality to each other. Harm reduction must center Black people if it's going to truly make a difference in our health, our dignity, and our spirit. Not just inclusion for optics. Real leadership, real ownership by us, for us. When we say all hands on deck, that has to include Black people, especially Black people who use drugs. For many of us, the concern isn't being free to use publicly or asserting identity as a drug user. We're fighting for our lives. We're grappling with our mortality, with the trauma passed through families by the war on drugs. We're criminalized before we even take the first hit. And I get it. It's hard to embrace harm reduction for some people, especially when you know somebody in a stage of chaotic use. And I can't promise a turnaround today, tomorrow, or even next week. Care does not need to be transactional. But what I do know is that they have to be alive to make any change. We need to move beyond respectability politics and moral judgment. We need to bring harm reduction and drug checking to our people. Sorry, somebody's calling me right now for some reason. And at the very least, we need to start a dialogue. Next slide, please. I'm going to give you a quick rundown on the tech we're talking about today, but don't worry, you'll learn more as we go on. It's just, these are the basics. Most harm reduction-based drug checking programs use 3 types of technology, mainly. Test strips, these are easy to use, portable, and don't require much training. FTIR machines, these analyze the chemical fingerprint of a drug to identify its components on the spot. Mail-in or secondary testing, now this type of testing offers a deeper analysis from a highly sensitive lab machine, and it can detect trace substances the FTIR might miss. Lots of orgs begin with just strips and lab testing while they build infrastructure to bring an FTIR machine in-house. And that's exactly how we started in the East Bay. Next slide, please. I also quickly want to show you 2 examples. Oh, next slide, there we go. I also quickly want to show you 2 examples of community-owned data. These are from HEPAC on the left and Punks with Lunch, both from Oakland. They use this to inform, protect, and empower the community by sharing what's in the local supply through monthly newsletters. In one case, the one on the right, the team from Punks with Lunch had been hearing multiple reports of overdoses in a specific neighborhood. That same area is the one in the bright green, is where they collected a sample. When they tested it, they found it contained carfentanil. Carfentanil is an analog of fentanyl that's about 50 to 100 times stronger than fentanyl. Without drug checking, we wouldn't have known why people were overdosing. That information matters. It can save lives, and it allows people to have a conversation in the first place. Next slide, please. The last thing I want to pinpoint before I turn it over is that when our communities get involved, we move mountains. Just one example is in St. Louis. There was an effort to get the Black community truly involved in harm reduction and outreach. When Black people go out and serve their neighbors and their families, amazing things happen. Overdose deaths went down by 46% in the span of 1 year. This shows how we make a difference and how we matter. So on that note, I'm going to stop talking. I want to introduce Leonardo. Leonardo
Before we
is an
start with Leonardo, I'm sorry, Shimeko, I'm sorry, just for the audience. So we have chat disabled, but use the Q&A to let us know who you are, where you're tuning in from, and that's where we're going to be gathering questions and comments. So thank you. Thank you, Shimeko.
Thanks, Tracie. Sorry about that. All right, so I'm gonna introduce Leonardo to you. Leonardo is an epidemiologist and researcher who's working with and alongside the harm reduction community, and he's been doing it since 2009. He's currently the lead drug checking technician at the New York Department of Public Health and Mental Hygiene, and one of the handful of Black drug checking technicians in this country. Leonardo.
Thank you so much. Again, so today I'm going to describe a little bit about my experiences serving the communities I'm a part of here in New York City, and a little bit about our drug checking program and the things we've found. Next slide, please. Like Shimeko said, I am now one of more technicians in the country, but at some point when I began my training, I was one of 4 fully trained technicians in the country, and maybe the only Black technician at that time. Luckily, the community is growing, and I know a few more folks that look like me that serve our communities. Next slide, please. So drug checking is really a conversation, and it's a conversation where we can provide information to our folks that matters in terms of when they're going to make a decision about the drugs they consume. It is one thing to say, I'm using this. It is another thing to know with more certainty. And that's what drug checking allows us to do in community. We get to have conversations and discussions with actual real-time information tailored to the specific person and the sample that they're choosing to consume or not consume, depending on the information they receive from me. Next slide. Our program uses all 3 of the main drug checking technologies available. We use a Bruker Alpha Transformed Infrared Spectrometer, or FTIR, to provide real-time analysis to our participants. That has a limitation of a 5% detection limit, which then we also combine the use of immunotest strips, such for fentanyl, xylazine, benzodiazepines, and these are very sensitive and can detect very small amounts, but only really allow for a yes or no answer. Next slide. And then in combination with those frontline drug checking services, we also send a small amount of sample to our lab partners, who then do much more sensitive analysis and destructive. I think a really important part of the FTIR testing is that it's non-destructive, so participants can have their samples back unless they want further analysis with secondary testing, which we ask for. And it's more expensive, but it does break down smaller quantities of substances present. It has a far smaller detection limit than the FTIR and can detect substances in trace amounts. Next slide, please. So drug checking, the process is truly a conversation. I currently do drug checking on Fridays at the OPC Overdose Prevention Center in Washington Heights, and I'm in the room with folks as they are coming in to use. A big part of it is people come and talk to me and ask me, hey, what have you been seeing in the supply? Or if somebody picks up something new from a different person, they're like, hey, Leo, can you check this for me? I just got this from somebody new, or if they've had a bad experience. So it really does all start with a conversation. At this point, they know there's a short survey associated with the work that I do in the space, but if they don't have the time for that, we let them submit minimal information anonymously. But I take the sample, I analyze it, and report back to them. Some participants wait to have the information. Some, use my services after they've used and experienced something, whether it was pleasant or not. Next slide, please. We currently have 6 sites. When this program started in November of 2021 by Yarelix Estrada, I was pulled in December, January, and then eventually began my first drug checking site in the South Bronx. I'm very loyal to the South Bronx and to the Bronx in general for all it's done for me over my career. So I continue to push for services being provided in the neighborhoods where it's most needed. Today we have 6 sites. I currently am responsible for the South Bronx site and the Washington Heights site. But we have a wonderful team, and we provide drug checking services Tuesday to Friday, by fully trained drug checking technicians. Next slide, please. On this slide, you can scan this to get our schedule for all our sites and the locations with contact information for how you can reach us and our sites, because all our sites right now are syringe service programs and provide a variety of services, and they're all really great at what they do. So whether it's drug checking services or other harm reduction services, our partnering sites may be able to help. Next slide. So up until this point, our program has analyzed over 3,000 samples belonging to about over 500 individuals. I was looking at my data today. I've been responsible for about 1/3 of these samples. So I've analyzed over 1,000 samples at this point since 2022 when I began my community facing work. And undoubtedly, I've served people that look like me, whether they are Latinos from the Bronx or Black New Yorkers. Undoubtedly, I've been serving my community, and it's very fulfilling work in that way. Next slide. One of the major trends we've seen is that things that people come to us and tell us like, oh, this is my bag of opioids or dope or heroin, is that fentanyl has been a common thread throughout a lot of our opioid samples. 96%, to be exact, produced a positive test strip result. Next slide. Now, we've also tested over 1,000 non-opioid samples, and this can be cocaine, amphetamines, and only 1.6% produced a positive fentanyl test strip result. And this is not indicative of fentanyl contamination, because a lot of these samples that produce a positive fentanyl test strip were later identified to not contain fentanyl by our secondary lab analysis, and nor was fentanyl found on our FTIR analysis. But test strips sometimes have some cross-reactivity and can produce false positives. So I think it is really important to use all the technologies together as much as possible. Next slide. And I will also say that something important about the false positives and identifying fentanyl and non-opioid samples is a lot of the samples where we thought we were identifying fentanyl, we could undo that thought by having a conversation. So something about doing drug checking in community and not this just being some random sample is also very important. Those conversations really help kind of identifying what is going on with folks and what part of their lives might lead to the sample looking the way it does. In our opioid samples now, some of the cuts that we've been seeing and identifying recently have been xylazine. It was first identified in November of 2021, but its prevalence increased steadily since across the time of our program. At this point, we're at about 43% of our opioid samples contain xylazine. That's a veterinary sedative that does not respond to naloxone. But with that said, it's important to note that it's almost exclusively found with samples that also contain fentanyl. We're not identifying xylazine in samples that don't necessarily have fentanyl. Next slide. Now, as laws and things crack down on the presence of xylazine, another tranquilizer or veterinary sedative has entered the opioid supply. Medetomidine is similar to xylazine and that it's not an opioid, but it is a long-lasting anesthetic that's more potent than xylazine. So this is something that we can attribute to the heavy sedation. But something that I forgot to mention with xylazine, xylazine has been associated with wounds, and that is something that we're not seeing with metometamine in the supply, but it brings its own set of complications. To date, we've identified metometamine in about 105 samples. And again, the first identification was back in June of 2024. Next slide. And this message kind of remains strong. A lot of people always ask me like, oh, are we going to get a new naloxone for xylazine, a different antidote? And truthfully, the message remains that naloxone is the most helpful tool when it comes to combating overdoses. Fentanyl is still the leading fentanyl is still the leading drug involved in our overdose deaths in New York City. And naloxone will continue to be an important tool to save lives. Next slide, please. So yeah, some of the key takeaways here are that supply in New York City is very complicated and volatile. In New York, it continues to be older Black New Yorkers that are, succumbing to overdose at higher rates. And honestly, it's an honor for me to serve this community and to try and turn these trends around. And the truth is that point of care harm reduction education is a very crucial component of our drug checking program. And I think it helps when I reflect the community I'm serving. Next slide, please. And these are some of the products that we've been able to create as a health department, because not only do I have my responsibility to my participants in front of me, but we also try and, inform other service providers across the city. Back in 22, we did a health network advisory on xylazine and fentanyl. We've created language around xylazine and kind of how to respond to xylazine-involved overdoses. And as the end of last year, we did a health advisory on the presence of carfentanil and metometamine in the New York City drug supply. Next slide. Well, thank you so much. You can reach us at the health department here at our drug checking at health.nyc.gov. And I will pass this back to Shimeko. Thank you.
Thank you so much, Leonardo, for that presentation and telling us about your experience in New York City. Lastly, I want to introduce the legend himself, Mark Jenkins. He is going to tell us more about his story and how to bring this technology to your community. Mark Jenkins has spent the last 24 years in harm reduction and in public health. He has developed innovative preventative strategies for vulnerable populations across Connecticut. As a respected voice in the field, Mark has presented nationally and internationally on best practices for working with people who use drugs, building extensive networks that connect street-level communities with service providers. He was an early adopter of drug checking in Connecticut with experience with the handheld Raman and FTIR. Mark Jenkins, everyone.
Forgive me if I'm a bit technologically challenged on this end. Thank you guys, those who shared before me.
Elder statesman, please speak louder.
There you go with that elder statesman shit. I'm not that old. All right. Actually, I am, but I'm not elder statesman. Good afternoon, good morning, good evening, wherever you are, if you're around here. Mark Jenkins. I don't know if I deserve the accolades that sometimes are bestowed upon me. Guys, I'm a harm reductionist. I mean, as a dear friend of mine say, I'm a streetologist. It's my job, it's my duty, it's my calling. If there is something that is being used to benefit my community, the people I serve, then that is what we need to be focused on. We need to pay attention to the various trends, what's happening, and how do we get ahead of those curves to make sure or ensure that we're able to get funding to meet those needs. So when things are like this, popped up, number one, I do have some geek still buried inside my frame, and I was captivated by the technology and the fact that it also lended for me to get together, like, early on with some of my dear friends as we gathered in places like Massachusetts. I remember, I think some of the first ones to receive FTRs were like, oh my God, she'll kill me, up in Boston. It was Sarah Mackin, and then I believe the folk from Chicago flew out, and there were a few different technologies available, that 805 that might have been short-lived, the FTAR, as we continue to use. And I also helped build a library for a spectroplasmonic, a Raman machine that I like, and because of its ease of use and the having the ability to have that information read in a cloud-based format. However, as time has gone on, it seems that the FTIR remains that vehicle by which we're able to continue to utilize. We have one that's been in use now for a few years. And having that, the ability to partner with organizations like Brandeis, Tracie Green and her team, and learn from Cole and those guys, and just having that ability. I knew early on that it also requires someone dedicated to learning it, but not just learning it, but being able to disseminate the information to those funders, to those other folk, to see where the value in this information lies. Because as they said, that I think Leonardo alluded to, there are some, it's limited in its scope to what it can do. And so, like, early on, we partnered with our state lab and made sure, like, even early on, we made sure, like, they got urine samples because they were learning how to read, they have the GCMS to read urine samples in decedents. So we provided those samples, and likewise, we make sure even now everything that we test, we as well are using fentanyl test strips. We've gone through now thousands of various different bags, and whether it be, crack that's coming in, because unfortunately in the African American community, we have, the fentanyl has just proliferated the drug supply. And although we don't see it in marijuana, that's the kind of bullshit that you hear from folk on the sidelines or who really don't know. Yes, it does turn up in crack, and we do and have seen, especially in Connecticut, multiple people who have perished as a result of, excuse me, guys, as a result of their being opiate naive. Uh, and so making sure that we're able to continue to disseminate information, where we actually have an FTIR right now on the way, which will be specifically for mobile. It will travel various parts of the state and be able to do some testing in people's local areas. I think this is hugely, hugely important, because this administration, um, as if funding wasn't already challenging, um, the direct attack on organizations across the board, and how this will affect especially those smaller organizations that do reach directly into Black communities. And the fact that we have to it's challenging at times but we have to get outside of those just business as usual, and find out what's going on, like with settlement monies in your community. That's, if that's not a screenshot behind me. This right here is a result of making sure that we're able to supply, syringes in our state. And then also, as you see, other vehicles such as our United Syringe Trust, we have to be able to stand in a place and meet the needs of those. With CTHRA, we talk about standing in the gap. It's always been one of those things that these services were provided to stand in the gap because, I'm not going to go into I'm not going to get on my soapbox, but traditionally syringe service programs were run by gay white men. They were in ASOs, AIDS service organizations, which basically, they had a lane. And while we have to be grateful for all of those that came before us and laid this work out, my predecessors always told me, Mark, just get that work done. Get that work done. And that meant that I had to make sure what was going on in our communities, that we were getting those services and those needs met. And that's everything from more syringe access, which is that platform that I stand on, making sure that we had this technology early on and learn how to use it, disseminate the information and disseminate it in a way that people could benefit from it. And as a result, I was able to partner with our DPH and then with HIDA, Bobby Lawler here in Connecticut, who in turn did some work with Tracie Green and Brandeis, and they developed something that benefited, the I-91 corridor. So being a part of those from the start, a part of that conversation, being a part of the early AC/DC conversation and being there in Chicago for the first convening, all these things were just setting in place a standard for us to get this work done in our community in a way that benefited our community. Definitely can't, not mention our national folk that have always been a part of this and continue to. But I'll leave that at that. But I mean, just making sure that we're able to disseminate this information. I can, I don't have to show you. I've got just samples everywhere. But I think that's about it for me. Tracie?
Okay. So thank you, Mark. And again, as the inaugural board chair for the National Black Harm Reduction Network, if I haven't said it lately, I am deeply grateful to you for all that you do, but especially in your support and work to launch this and get this going. We're all of a year old, folks. So we do have some apologies for the tech issues in not having the chat open, but I see, are using the Q&A to communicate with each other and maybe want to try to answer some of the questions that have come up. I know that Lawrence Grandpré from Baltimore uplifting the issue about the overdoses that happened in Baltimore recently. Thank goodness, as far as I know, no one died. And as far as I know, a lot of that was because of existing harm reduction folks on the ground who were close to what's going on. But there were, I think, let me talk a little bit to Sean's question about settlement money, because this is a big concern for many of us. It's a big advocacy focus for NBHRN, for National Black Harm Reduction Network. And so settlement dollars are a result of the states, every state attorney general being part of a giant lawsuit against manufacturers of various prescription painkillers, and the beginning of the prescription painkiller epidemic. And it was attributed to these companies knowingly and uncaringly not being honest about the addictive nature of the prescription painkillers, and that they kept pushing them out despite knowing the dangers of them. So every state was awarded settlement money and continues to be awarded settlement dollars from the litigation that happened between the state attorneys generals and these different companies. Many of you may have heard of the Sackler family. They are a big offender, although none of them ever admit guilt. They just put payment in. And so the agreement, the settlement between the attorneys generals and these companies has resulted in millions, billions of dollars coming into the states who have struggled with the overdose epidemic that was very much driven by the prescription pill epidemic, which then, because they prohibition on those pills, made a demand for heroin. And as we know, prohibition tends to lead to black markets and people dying of unregulated and supplies and criminalizing people. So every state has a settlement dollar. I would recommend you go to an amazing site called the opioidsettlementtracker.com, all one word. Christine Minhee is a young lawyer who gathered up all the information across all the states and all of the language of the settlements to be able to give people a sense of what their state is getting, the circumstances under which they're getting it, and the approved uses for the dollars. These are tables where money is being discussed. And if you're not at the table, you're on the table or you're left outside. And so what is true is, as overdose mortality and morbidity, right, as we die and get sick from overdoses, disproportionate to our population in these states, we need to be at the table. And so please stay tuned with NBHRN, because that is something that we're going to be doing with our partners in different states. Opioid settlement funds are not national dollars. They're not federal dollars. They can't be touched by this current administration, but states are all going to have to look at those dollars in addressing overdose and the issues related to overdose, as we're seeing less federal support to address these issues. All right, let me hush because I see there's more questions. And Mark or Shimeko or Leonardo, please feel free to come on and answer any question you see.
I know one came to me from John Sabell, who does some work down in North Carolina and actually a lot of other areas around.
Get closer, sir.
And talking about the challenges of drug checking in areas that are overly policed, and there is a huge difference even here in Connecticut in different areas. I will say early on that because of our partnership with various folk and the permissions that we received on the front end, and even the verbiage around drug checking, has helped us tremendously. It can't go without saying that we do have areas where people are, more afraid to come forward and do any type of sample provision for drug checking. We have been in our two larger areas where we focus right now, again, I'm going to say we have been extremely fortunate that it has not happened, but we do see it in rural areas where people are targeted. They're definitely targeted, and it makes the work a lot more difficult. And I don't know if Leonardo, if you can speak to that.
Yeah. Um, I mean, the work is hard between losing people more frequently than other lines of work and just the unknowns. I'm sorry, Mark. I got a little distracted by the questions in the chat. Which part was it that you wanted me to speak to a little bit more?
Uh, Trying to conduct drug checking in overly policed areas, or is it the same in Black communities as other communities? How does it vary? You know, say poor
This is,
poor
yeah.
communities.
I've had some interactions with folks in like more rural areas, and the communities are just so much smaller that they struggle with anonymity just because, like, hey, it's a town of 500 people just know each other, and if they're walking into this space here in New York City, we're like 10 plus million. It's a little more anonymous in that way. But I think a conversation I always have with my team, I'm like, I'm the one Black man on our team, and we have this fancy little letter that says, "Oh, this person is doing official business for the New York City Department of Health. They may be carrying drugs on them," and like sometimes we get this sense of like, "Oh, we have this letter. It's really cool," and I'm just like, "Y'all, the way this works is this will get litigated, and you will be okay at the end of it. But like, it's not going to stop police from taking me in if they want to. It's not going to stop." Me from sitting at the tombs over the weekend if it happens to be on Friday after drug checking in the Heights. So like I understand that I work for the government and I have these fancy levels of protection, but the truth is that they're not real in the sense of like in the moment, no police officer is going to look at my official letter and be like, "Oh, I'm so sorry I stopped you, young man." Like it's not going to go that way. So I think that sometimes is yeah, it's just like real and like luckily, I would say that our partners here in the city all do a lot of work to try and avoid ever having to involve police in any of their responses. I would say that it's rare that On Point calls 911 to respond to overdoses. They have their things down pat. And then I would also say that we have a lot of eyes on the ground and we have feet on the ground. We are currently doing this pilot program with the Peer Network, where essentially we're teaming up with the Peer Network of New York to have people who are respected members of the community and trusted, serving folks in areas where our program doesn't necessarily reach, or trying to reach people that don't necessarily get reached through our normal means of drug checking. So they hit like samples on the weekends from areas that like have been highly policed. So the hub in New York City, if everybody saw, there was this big sweep of this area in the South Bronx. We found out very quickly because the peer network was there doing their regular weekend outreach, and they're like, "Yo, police cleaned this out. Like, what's up with this?" You know? So it was kind of, I think those are the things that help. Honestly, like trust, there's nothing like trust in community. It's hard work. People don't trust you at times. Even when I first showed up in Washington Heights, it was very much like, who are you? What are you doing? And and like, and there's this ongoing joke about what drug checking is. And it's just like it took time, but now people like know me, trust me, and don't mind. And like I think it helps when you're situated within a program that is providing services like an overdose prevention center. I would say that each of our program sites differs depending on the culture and the environment that we're in. And we try not to impose, as the health department, we don't try to impose kind of like, this is how your model needs to look. If I need to be on an outreach vehicle, I'm going to be on an outreach vehicle. If I need to be in the OPC, I'm going to be in the OPC. If I need to be in a room off to the back, like that's where I'm going to be. We really try to work with our program partners as much as possible. There were a couple questions here in the chat directly to me. And I was going to say, Mike from Oakland, we don't have black tar. And I actually had somebody bring me black tar heroin on Tuesday to test. And I was like, my first question was like, where'd you get this? And he was like, oh, I was like, actually, I said, I was like, did you get this online? And he's like, how'd you know? And I was just like, well, we don't have black tar heroin in New York City. Like that's not a thing. We do still have heroin and those samples pop up, but like it's not that all dope contains fentanyl, but a lot of our dope. So I think in our samples, it's been 96%. And then to the stuff about stimulants and opioids, I can't speak to all of the supply in New York City. So I can say that we don't see it in our program, but that's the small population that we serve and the people that come to us. it's seen in other data sources that the city has, mortality data and things of that nature. But I will say that something that's specific to drug checking is that a lot of my folks do enjoy a speedball. And sometimes I have to ask them mid-drug checking, like, hey, is there supposed to be cocaine in here? Because I see it. And they're like, oh, yeah, I mixed it. It was, it was my speedball and things of that nature. So I would say that while we're not seeing it in our data, that doesn't mean that it's not happening. And I think for me, one of my goals is to expand this to try and be able to say a little more about New York City as a whole, and try to serve more people and cover more of the city with our services. So yeah, I don't want to say that it doesn't happen, that opioids are being found in the stimulant supply. It's just not something we see.
Well, I don't know, but I want to cut you off, Leonardo, but
Mhm,
in my community, and because also, um, because stimulant was, was my drug of choice, and growing up and having an organization in the city in which I lived, I've witnessed over the years, even people who worked for me that were opioid naive that died as a result of their smoking, their crack use. On our wall in our drop-in center, and I'm in our warehouse right now. But if
mhm,
I was in my drop-in center, I can think of at least 20 people over the past 3 years that have succumbed to a fatal overdose as a result of opiates being in the drug supply. And
mhm,
there was a period, I want to say, I don't know if it was 2 or 3 years ago now. I think I'm losing track of time. Maybe that's that elder statesman stuff, Tracie, uh, where we had, I believe, about 15 fatalities in a 48-hour period. And then me, being able to really, like, we were able to even target and get samples. And it all comes down to, it was a mistake or cross contamination. But it's not, by and large, anything that we see, you know, just targeted, but it just happened to hit this particular
mhm.
Black community in a Hill district or a Hill section of Hartford.
I just
Yeah.
wanted to really quickly address the discussion about areas that are a little bit more aggressive as far as law enforcement is going, and just bringing something to your community when you're out in the open. And I think one of the things that we talked about a lot here in Oakland was an MOU with the law enforcement, but eventually we decided that that was not what we wanted, because we didn't want to put ourselves in the crosshairs of law enforcement. But a big way for us to strategize about this was talking to other people that were doing drug checking across the country. And so I just wanted to highlight a little bit Remedy Alliance here. Remedy Alliance is, they're kind of teaching everybody across the country how to do drug checking at this point, because there wasn't really infrastructure in the beginning and people were just sort of learning, like Mark talked about, like, there's this technology, I want to figure it out, I want to bring it to my community. But Remedy Alliance sort of gathered all those people together that were doing it, and now they're training people how to be managers and drug checking. And they actually have office hours. I think it's every other Wednesday or something like that. And so a lot of our strategizing, and I think a lot of people's strategizing, is going to Remedy Alliance calls and talking to people that are doing it. And I think that that's a great way for you to start understanding and thinking about what it's going to look like in your community. So we have their website here, and I also just want to shout out that they are contributors to NBHRN, and they're also really trying to make something equitable happen in harm reduction, which oftentimes like puts us on the back burner. So I just wanted to shout that out, and I think that they're a great resource for anybody who's starting drug checking or wants to know more. Oh, and I have their office hours is actually, or their drug checking office hours are second and fourth Wednesdays every month.
Also, I see we have Nason up there. I'd be remiss if I didn't mention we have to talk about points of distribution. Is also another one of those sites that makes sure you have access to fentanyl test strips at a reduced cost. Uh, Fentanyl test strips, xylazine, and as well as being a mutual aid for smaller organizations as well.
Mark, I'm going to ask you to say that again
I
in your
said
outdoor voice.
I would be remiss if I didn't mention, we have to mention points of distribution also. Points of Distribution is another mutual aid organization that has low cost. I won't say they are low cost. They are lower than they would be generally, but fentanyl test strips, xylazine test strips, they also, they do a lot of work. Feel free to reach out to them. I know we're getting ready to end, so I will add also one of the newest mutual aids to the group, the United Syringe Trust, which I'm also the executive director. And, you know, as a result of just years of trying to build upon syringe service programs, we're now able to meet some of the needs of programs that are either in between funding, just out of stuff. And we're going to be hosting a pre-conference at the DPA conference coming up in November. Feel free to reach out to me by email, as well as with Tracie. Let Tracie know, let me know if it's something you would like to do. I'll make sure you get a link. We have a brief survey. Listen, we're stronger together. This is what this is all about. This is about being stronger together. Listen, it's a rough environment, and it's gonna get rougher with the bullshit that this dude is serving up. So we have to make sure that you have support, and that to know that you have support. That's what NBHRN is about. You know what I'm saying? That's what the other organizations that we're talking about, Remedy Alliance, these are folk that have been doing this shit for years that really want to be there to help you remain in the game.
Thank you, Mark. That is perfect. Leonardo, I see your hand up. Did you want to get in something that folks should?
Remedy Alliance. Yes, shout that out. But also Tennessee, somebody asked about doing this in more conservative spaces. And a place like Tennessee, they're doing something really interesting where syringes are allowed by law to be tested. So they have a drug checking program that is only the lab partner based, but they're able to kind of work around some of the limitations in their jurisdiction and test syringes out of their 2 syringe exchange programs. So it is always really just trying to work around things until things and trying to push things in the direction you want them pushed. But that was it.
Absolutely. And so we are at the hour. We are under no illusions that, ears and eyes are everywhere. But because we are a network, that's about getting the information to each other in whatever ways we can. And so, again, we chose to do this a little non-traditional, which is to bring together your questions and your answers to be an ongoing resource, because we are each other's resource. I would also put in, as shameless, but not, is we have to take care of one another. And so the idea that we have to support the resources that we care about. So if you want to make a contribution to NBHRN, any amount keeps us free from dollars and funding sources that would muzzle us or have us do things in ways that we're not going to do. We just not going to do. So we will, give us at least a week to compile the questions, answers, categorize them, and get the recording together. It is my hope that this will be the first recording of a newly launched YouTube channel. We want to be a reliable resource to our communities. And I want to thank so much Shimeko, Leonardo, Mark, as always, Dominique, Desh, and for those of you who know, Eileen is the Eileen. We can't do this without Eileen. So we will be doing this again soon. We will send information out about DPA in November because we're going to be doing something big out there too. All right, take care. Stay careful, everyone.
Thank you, everyone.